You're listening to a Raconteur Studios podcast.
Hello and welcome back to the After Hours Skin Clinic. I'm consultant dermatologist Dr Emma Craythorne, and this is the podcast that answers all your biggest skincare questions after the clinic doors close. This week we're talking about something everyone should know about, but that's woefully under-discussed, and that's the vulva. We're going to be talking about what the vulva is, what kind of changes happen to it over time, and we're particularly going to focus on a time in a woman's life that is probably, I'm going to say, the most empowering time of her life, where she's not necessarily under the reproductive control of hormones, but has acquired a sense of serenity and wisdom. But that also comes with some changes within the body for some people. I'd like to talk a little bit about what those changes are and simple things that we're able to do to approach them and keep life entirely as good as it can be. Because often this is a subject that isn't discussed, people can have trouble in this area or feel great discomfort, and it can have a significant impact on quality of life. So today we are going to break down the taboo, because it shouldn't be a taboo, and we are going to talk everything to do with the vulva, whether that's dryness, itching, sensitivity, and changes in appearance that can happen. And today I'm joined by the most amazing GP, and I'm not biased whenever I say that, also my dearest friend, all the way back from medical school, and a very special women's health expert, the absolutely wonderful Dr Sigi Joseph. And we're going to explore what's normal, what's not, what we can pay attention to, and what interventions we can make to change things. So Ziggy, my darling, welcome back to the podcast.
Hi, thank you for having me back.
So shall we start with the very simple thing of what is the vulva? Can you tell our listeners?
Yeah, so the vulva is the anatomical and correct term for all of around our vaginal area, including the labia majora, so the bigger lips on either side, labia minora, and then the vaginal entrance and introitus, we can call that. So that's what the term relates to.
So when somebody says the word vulva, that is the entire area.
Yeah.
And the vagina is the tube, essentially, that goes up inside. And then you have your labia majora and your labia minora.
So those are the two. So labia majora being bigger or on the outside, and the labia minora on the inside. You've obviously got your clitoris at the top, very important part, and the clitoral hood.
Okay. Lots of things change over time within the vulval area, and I thought today we could specifically talk about the changes that happen during that perimenopause and menopausal time, because, I mean, you're a GP, so you'll be seeing patients in clinic all the time, and I bet you loads of people don't even bring that up, even though they might be having problems with it at home.
Yeah. Very important, and they actually talk about it almost being a silent epidemic, because it's an uncomfortable symptom to talk about if you've got some changes there. There is also this feeling within clinicians and certainly menopause experts that lots of women accept changes down there as normal parts of ageing, when actually there's a lot we can do about it. So there's partly the patient acceptance, where they just think, well, I'm just getting older, that's part of life, when actually no, there's cell changes that can be addressed and we can do things there. And then there's the embarrassment factor, and also clinicians maybe not taking that extra second to ask, how are your vulval symptoms? Have you got dryness, irritation, discomfort? Can lead to urine symptoms as well.
People don't even understand necessarily what's normal and what's not normal. So actually, because it's not talked about, women can continue then to experience symptoms there that's, passed off as being entirely normal, when in fact it's part of a disease process, or it is abnormal.
Yeah, it is exactly that. It is part of a perimenopausal change in hormones, and it doesn't have to be grin and bear with it. There's lots of things we can do, and understanding your own kind of vaginal tissue. How does it feel? How does it feel when I have sex? How does my tissue feel down there? Am I more aware of pain or discomfort? Then just tuning in with yourself, a bit like a lot of perimenopause. Everyone's experience is different, so understanding what's normal for you and what might need addressed is really important.
So let's just clarify for anybody listening who doesn't realise, what is perimenopausal, premenopausal, postmenopausal? What do those terms mean?
So the terminology is often mixed up. So the menopause actually officially relates to 1 year after your final period. So if you think about it, it's almost just one day that they're talking about. And that's 12 months after you've last had a natural period. Now, for lots of women, that's difficult to know because they might have contraception that stops their period. But officially speaking, your menopause is 12 months after your final period. Everything from that day onwards is your post-menopause. And with life expectancy now, it's believed that we'll live up to a third of our lives in post-menopause. Perimenopause is that period up to that menopause day. So perimenopause is that time before we reach our menopause. It can last for some women, symptom-wise, 3 months, 6 months, but other women can experience symptoms for up to 10 years before their menopause. And what's happening in that time is our estrogen levels, our ovarian function is really changing and our estrogen levels are fluctuating. And it's those fluctuating hormone levels, particularly estrogen, that give you the perimenopausal symptoms.
And so what kind of changes happen in the skin and in the vulval area?
So the vulval area is an incredibly complex and clever area of our body. So we've got lots of different things going on there. So we've got the vaginal microbiome, so a bit like the gut microbiome. So we've got normal healthy bacteria. And if a woman was to get an overgrowth of unhealthy bacteria, that's where we might get discharge and discomfort. So lactobacilli being the most common healthy bacteria we've got down there. Our tissues down there, so the cells down there, produce secretions. And when we've got normal estrogenization, we've got plenty of estrogen around, that secretion changes over approximately every 4 hours or so. And what that does is actually promote something called glycogen, which increases, which basically then promotes the lactobacilli, so that healthy bacteria. And that supports our vaginal skin and it supports the pH. So our pH being 5.0 or lower kind of again is a protective factor against infection, urine infections and overgrowth of unhealthy bacteria. So that's one process that's going on. And then the other one, which you know an awful lot about, Emma, is around the collagenization of those tissues. So again, the fibroblasts are less reactive and then they're flattening down. The collagen structure of the cells is flattening down. And then that's kind of almost, you can get the labia minora can get flattened and some patients even have it fused and the tissue becomes a bit drier, paler and less structural. So prolapse can be a bigger issue then.
So I think what you're saying is happening over time is the collagen impact. So the skin's becoming thinner and it's just not as bouncy as what it would have been.
Yep.
But also this change of the skin microbiome in that area.
Yeah. And also the blood flow to that area reduces over time as well. So it's kind of all of those things that are happening that really lead to the symptoms that women experience.
And what are those symptoms?
So again, they can be really wide-ranging. A lot of people might feel, quite an extreme dryness, and other women will just have a kind of, actually, I never really was aware of my vulval area when I was wearing maybe leggings or tights, but now I can feel, it's a bit uncomfortable. So the dryness in itself can range from quite mild to really, really significant and severe and kind of disturbing sleep and that kind of thing. Because the tissues have less blood supply and are a bit flattened, they're more prone to trauma as well. And then if they're drier, if you're having sex and you get a bit of trauma, that can happen. But also even some women might even find if they've been wiping or jeans rubbing against them might cause little fissures and disruption to the tissue. So trauma can be a bigger problem. And pain can come from either the dryness or the trauma, or just generally some women feel it a bit more uncomfortable down there.
And do you get more infections as well, like kind of more UTI, bladder infections?
Yeah, so that is a great question. And that's another part of the symptoms that we get. So women will experience sometimes dysuria, which is pain on passing urine, more frequent, so needing to wee, not being able to hold on quite so well. So difficulty passing, peeing more frequently, and it's painful when you pass urine. Quite often that might be a urinary tract infection, which is a bacterial overgrowth. If you think back to what we said about the pH changing and the healthy bacteria imbalance happening, you can get more overgrowth and get urinary tract infections, but also actually just having the vulvovaginal dryness, genitourinary symptom of the menopause it's called, or urogenital atrophy. It's kind of got several names, which doesn't really help, I think, the public. But that in itself can mimic symptoms of urinary tract infection. So you do get a lot of the kind of changes to the way you pass urine
And what kind of number of women is this affecting? So, does this affect everyone, but just to varying degrees? And what percentage do you think it would be that would benefit from some kind of intervention?
We talk about it being 10 to 90%. So essentially, we don't really know because it's a very common symptom, but not necessarily reported. So it's underreported. But I would say, everyone going through their menopause is going to experience changes to the hormonal nature of the tissue down there. And then that gives you symptoms, but to varying degrees, as I said.
And if somebody's listening to this and they themselves are a doctor or a dermatologist, well, doctors that are dermatologists, but I just know that lots of dermatologists actually listen to the show. But if they are listening to this, what kind of questions should you be asking as the healthcare professional to a woman who is perimenopausal, menopausal? How do you introduce the subject? How do you talk about that?
Well, for me, any person I meet and I'm having a hormonal chat with about whether it be difficult periods or post-pregnancy or pre-pregnancy or particularly perimenopause, I always ask about any discomfort, pain on having sex as well, and any difficulty with going to the toilet, with bladder or bowel. So I think if you're doing a consultation around skin, you're asking about menopausal symptoms, because it's, again, a skin area, just saying, do you have any symptoms around dryness, discomfort? Have you noticed a change down there? And you can use the umbrella terms of urogenital atrophy, but to the patient, it's just, have you noticed a change? Are you having any discomfort, and can we address that for them?
And then what can you do? What are easy things that people can do at home, or what advice can you give, or medicines can be given to help this?
So again, there's a wide range of things that we can do. The first thing to say is don't ignore it. So if you've got symptoms and you're embarrassed to talk about it, if you leave it, it's a kind of chronic progressive thing. So the earlier, like a lot of medicine, the earlier we get
like
everything, when you recognise it and you think, okay, things are changing, it's addressing that. I'll talk first about just really what the majority of people can do. There's some exclusions really, but it's first of all the basics. Stopping smoking, because we know that actually smoking in itself can affect estrogen metabolism, so it can reduce your overall estrogen. So that's a really simple thing you can do. Drinking plenty of water and avoiding those bladder irritating drinks. So lots of caffeine or fizzy drinks can make your bladder more irritant as well. So if you're having lots of frequency and you're finding it sore to go to the toilet, have a look at lifestyle things. Then it's about what topical treatments we're going to use here. So there is HRT that we talked about on the last podcast. That's systemic HRT that might go kind of through a gel or a spray or a patch, or you might be even taking a tablet HRT. That can help to an extent. But when we talk about the vulval area, we're talking about local HRT. Before HRT, there's moisturisers and lubricants. So for me, lubricants have more of a kind of in-the-moment effect. So you can, particularly if you're having difficulty with sex, penetration, you can use lubricants. Moisturisers you can use more regularly. So you might do a bit of an intensive treatment to begin with and then use it 2 or 3 times a week. And those moisturisers are broken down into oil-based or water-based. So they've got different qualities depending which one you're using. They can make some effects. You can make me maybe feel a bit more comfortable, less dryness, maybe a bit less trauma because you're less dry. But what we know is replacing the estrogen content there is really important to help those tissues. Remember what we said about the secretions changing over and promoting the good bacteria. So adding in the vaginal estrogen can help with the collagen, and it can help with the pH balance and all the tissues improving with blood flow as well. So it's over time when you reintroduce some local HRT, we call it, so it's local estrogen, it can increase the blood flow, restore that healthy bacteria, and also help with the collagen restructuring as well. That comes in various forms. So there's different types of estrogen that we use, and you can get them in tiny little pessaries. You can have it in gels or in creams with dispensing unit. And there's even a ring, small estrogen ring you can insert there.
And so when you're applying the gel, how much of the gel do you apply? Like how far do you apply a gel? How do you know that you're applying the right amount?
So all of the medicines that we use have, their instructions to begin with. So if I'm seeing someone in Scotland, what's really popular is a cream. So we use some estrogen cream, for example. That's very popular. It comes in a dispensing unit that's almost like a little calpol, like a little syringe, and it gives you exactly the right amount, and you put it into the vagina about an inch, maybe an inch and a half in, and then you just release the cream into that, and that works overnight. When you're starting out, you would say to a woman, use this every day for 2 weeks, and then they move to a maintenance, so they'd use it twice a week going forward, and you can use that indefinitely. We know that the systemic, so the body absorption of that estrogen is so small that it's very safe for the majority of women to use for a long, long time, and it can really offset that dryness, that propensity to urine infections, and try and help that woman. So even a lady in her 70s might present to me needing lots of antibiotics for a urine infection, and I'll say, well, you know, have you thought about some vaginal estrogen? We might be able to get on top of these UTIs if we do that.
That's very interesting, isn't it? Because I think that's something that is probably quite overlooked.
Yeah. So again, when I'm teaching, I'm always saying, look, along with the perimenopausal women who we're seeing more of, which is great, which is your kind of mid-40s onwards perhaps, it's all those postmenopausal ladies that are maybe 17. You look at their notes and they've had 3 sets of antibiotics in fairly quick succession, and you think, well, actually, they've still got the same issue. The collagen fibres are flattened down. The urethra, which is the kind of urine tube, which sits just there as well in the vulval area, can become a bit more exposed. So bacteria, again, can track up the way. So I'll very often talk them through, would you consider using some vaginal estrogen? That's separate to the HRT that we talked about.
And do you use both of them together sometimes? So HRT systemically and then the estrogen gel?
Yeah, absolutely. So a woman who is starting out on HRT and continues to have no risk factors, you can definitely add in vaginal estrogen. And I would often start all of them at once, depending on how you're presenting at the beginning.
And so can somebody who otherwise traditionally might not be able to have HRT because perhaps they've had some kind of tumour that's sensitive to estrogen and that's to be avoided, can they have estrogen topically?
Yeah, so this is a great question. And what it is at the moment, and again, I sit through various meetings where there's different schools of thoughts. If you've had an estrogen-sensitive breast cancer, for example, or some urogenital cancers, they don't recommend it, and it's not necessarily considered then safe to continue to use that if you've been using it. And you should try and move back to lubricants and moisturisers. So some of those cancers, you have to use medication, aromatase inhibitors. So if you've had breast cancer, you'll be asked to stop your HRT if you've been on it, and they'll say you probably shouldn't use vaginal estrogen. But they also put you on medications like tamoxifen, which you may have heard of, which is often women will go on for 5 years, or there's another one called letrozole that's very common. And those, again, are contraindicated, so you shouldn't use vaginal estrogen there. But again, if you look carefully at the guidelines and the NICE recommendations as well, you know, if a woman isn't getting any symptomatic relief from their lubricant and their moisturiser, it's that really tailored discussion around the actual cancer risk for this lady using that local estrogen down in the vulval skin. And some women, they will deem, okay, that's the only thing that's working for you. You can use it and balance that risk. So it shouldn't be a blanket approach for everyone. But this new medication is quite promising because it's showing good results. And it's not estrogen, so it's the DHEA. So it's got a slightly different mode of action. But again, it's just fairly new. So we need more studies with those patients that have had cancers and with the safety profile there. And it's thinking about the risk factors. So if you've got a lady who's already going through breast cancer treatment and is now 5 years clear, has had that medication, but she's got very distressing discomfort down below and constantly in pain, and none of the normal medications, the lubricants, moisturisers are not helping, then you're post your cancer treatment, what are your risk factors now? So you've got to think about that. But that's the group of patients that probably you wouldn't certainly as a GP automatically put them on vaginal estrogen. I would be asking, the cancer team, are you happy? What do you think in this situation? And there's other patients that we might, particularly those on those medications as aromatase inhibitors, we might not be able to use it with. But again, that's a discussion, I think, for that patient. It's good to advocate for them, talk to their team. The other interesting thing is if you're trans and transitioning, testosterone can actually promote vaginal dryness. So again, thinking about those patients and what they need and that, to help that tissue while they're in the transition.
Around the perimenopausal, menopausal time of a woman's life, it really is a time where you've got this sense of perspective, really, that you don't necessarily have all of the way through your life until you get to this point. So it is a very empowering time. You feel like you know yourself, you know your body, you've got your friends like you.
Yeah. When you meet, it's just that golden time. And I agree. You just know yourself a lot more and what you're willing to accept or not accept. So it's a very strong time in a woman's life.
But But there are some things that even amongst really good close friends that actually don't get discussed. I mean, I'm not sure you and I have ever discussed the skin health of our vulva.
No, we have not. Definitely not. We've always got so much to catch up on. But ask my sister, Sonia, who you know very well. She's saying, oh my God, I can't have a coffee with you without you bringing up vaginal dryness. And my daughter, did this Scottish Government kind of awareness video, and that was what I was talking about. And my kids were like, oh God, it's all over social media. But it's that exact thing when you're even with your close friends, you might just be chatting about other things and you don't get to that very intimate detail of your life. But everyone's experiencing it. So share it if you've got discomfort or you're not sure what to do.
Sometimes people, because it's such an under-discussed topic, that people don't know what is essentially normal and what's not normal. And I actually think that many medical professionals don't know what is normal and what's not normal.
100%. Because once we're trained in a certain area, that's often what you'll do. Whereas in my area, this is what I do a lot of. Like I wouldn't come and claim to know a lot about these complex skin things you're dealing with. So
although you do know a lot now, having watched every episode of the Bad Skin Clinic.
I've got a top fan badge for both that and the After Skin Clinic. But the thing is, it's actually just that thing of if you've got symptoms, you're not sure what they are, just talk about it, raise it. I feel like it's a bit like, post-birth as well. It's a bit of a mystery. And it's until, we had our first children a week apart. And that was so good for me. And even though we were in different cities, we were sharing, what do you think of this? Or what's happening around the baby or ourselves? It's the same, a lot of your friends are going through perimenopause around the same time, so it's useful to talk about your symptoms, and often that just gives you that comfort and reassurance that you need, that's normal or it's not normal, but there's things you can do about it.
And then not get sucked into advertising and marketing of products that say that they're going to do things whenever they don't, because again, that's just preying on another form of kind of anxiety. So
that for me is a big part of the Women's Health Plan. A lot of the work we've been doing is people are out there buying things, menopause t-shirts, different products that are being sold to you, and quite a vulnerable time. You're thinking, I'll just quickly try this, I'll try that, wasting money that you don't have. So definitely, that's very important. The other thing about this, Emma, is that I will see a woman who's maybe been struggling with symptoms, hasn't brought it forward, and then I see them and I say, gosh, we could easily manage this, and we try various creams, and often very quickly you're feeling better, and they'll disclose to me that actually I've been terrified to have sex, or sex has been sore once and it's put me off, or I've been too scared to even initiate or have sex. And the problem is the partners are sitting there thinking, they don't like me anymore, or they're not interested in me, whereas actually the female patient is thinking, I'm terrified to go down there. And intimacy isn't always about penetrative sex as well, so that's really important. So actually talking to your partner, saying, actually my skin's feeling a bit awkward down there, I need a bit of time to get some treatments, and actively talking about lubrication for sexual intercourse or penetration can actually bring people really much closer together. What I'll often see is the opposite, where maybe they've not shared with a friend or they've not shared with their partner, and sex has become a bigger issue. The marriage feels like it's under strain, and the partner's sitting thinking, what's wrong? Are they not interested? Are we not in love anymore? Whereas actually for the female patient, it's purely anatomical and they're a bit nervous. So it's again that awareness piece of like, actually, I'm sure if I just explain, if you've got most men are understanding and want to be helpful. So it's just say, actually, I just need a bit of treatment and I'm going to be better. There's an excellent lady who I follow called Ruth Ramsey. She's done a TED Talk. Actually, it was downloaded, I can't remember, several million times very quickly, about how to improve your sex life in a few minutes. And it's that key thing about, actually, if I share what's going on, then it's clearer why I'm maybe a bit apprehensive to have penetrative sex. And again, there are treatments for that, so don't ignore it.
And like you say, that conversation just breaks down a boundary, and actually it creates a different sense of intimacy, doesn't it?
Absolutely, yeah.
I think all of these things are so important to learn, because these things do happen as our bodies change, and you really want to be able to understand, first of all, that they're changing, and just slight different practices and things that you can do that means that the impact on your life is not a negative one, because there's a whole lot of positivity about going through the perimenopause and menopause time, really, isn't there?
Absolutely. And I suppose a lot of the work we're doing is more awareness raising of symptoms, partly because when I've met someone that's kind of gone through loads of symptoms, had very little support, you think we could have done more to help you have a really positive experience. There's lots of emerging research and much more clinical awareness about the treatments that we need. But also what I see with patients is it's a really empowering time of your life, and often sex lives can actually be improved because there's more communication with partners about what your needs are and taking that kind of charge about your symptoms, managing them well. And in the post-menopause, remember that these fluctuations, these big fluctuations are then settling down. And if you can then focus on postmenopausal health, so that's, weight training, looking at your diet and your exercise lifestyle, it's often quite a freeing time when the hormone fluctuations have settled. And again, the reason we're talking about the vulval dryness and these symptoms is thinking, well, actually, there's lots you can do about it. So don't just accept it as part of normal. Most of the treatments work really well and really quickly. So I do see women really quite strong at this stage of their life and having great sex lives and feeling just more in control and not embarrassed or ashamed to talk about things.
I mean, I think that's exactly right. It is a very empowering time of a woman's life. And yes, there are changes, but there are changes at every single point. During puberty, there's changes. During that midlife point where there's confusion around pregnancy times, post-pregnancies, a woman's body is always changing. And it's slightly recognising that. And partly as well, it is a slightly joyous time because it's then starting to get to, like you say, a time that is a little bit more settled.
Stable, yeah. And once we're in that post-menopause, those big fluctuations have settled down. You might be on HRT or you might not. And you're settling into your body and your power at that stage. So, yeah, I think when you list the symptoms initially, it can sound quite negative or quite alarmist. But actually, it's all more about awareness and thinking, okay, this is what's happening. I'm really lucky to be this age. And I've said to you before, if we're lucky enough to live till we're long enough to have our menopause, it's about addressing that, managing that and saying, okay, what do I need? And certainly not being embarrassed to talk to the doctor. I'm hoping that more and more doctors will ask you about it as a patient, but you bring it up if someone's not asked you, if you feel, okay, I've got symptoms, I need to manage it.
Because you imagine it kind of like all of your life, really, you're going through these monthly cycles of your body preparing. Are you going to get pregnant? Are you not?
Yeah.
And the hormonal shift and fluctuation that happens with that. And then the absolute serenity that comes then post-menopausally where your body's not even thinking about that.
Yeah.
You can see why in many tribes around the world that post-menopausal women are considered to be the most wise of all of the people. It should be the same here.
And that's very, very cultural, exactly that. In some cultures, that is the sage, that's the person you go to for the advice, and they're the leaders in that capacity. Yep.
Imagine what the world would be like if it was entirely ruled by postmenopausal women. It would be a brilliant place, wouldn't it?
Yes.
In terms of what's kind of commercially available over the counter, so there are lots of cosmetic creams and topical solutions that people apply to the vulval area, full of nice scents and herbal ingredients and all of these things. From your vulval health perspective, I mean, my view of it from a dermatology perspective, it's very, very unnecessary and is full of irritants or potential allergens and to stay away. But from a vulval health perspective, what do you think of these different topical solutions?
Well, I think there's two aspects. I will see women that have maybe been doing vaginal douching and using creams and washes, and that upsets the pH, that precious lactobacilli we talked about, and actually they'll almost get more problems, bacteria infections and things from that. I definitely say stay completely away from those things. There's definitely a growing market, much like a lot of the perimenopause, of things that some women might find is quite nice to use, but not necessarily got the medical evidence behind it. And really the key ingredients are that estrogen, and now we've got this DHEA cream. So those are the ones that we know are actually going to fix the structural changes that are happening. So again, it's all caution with, there's lots of things out there in the market that are sold to women that are having issues and they're kind of desperate to fix them. I would steer clear of anything that's not got all the correct process in place. Certainly anything perfumed, anything that's going to change the pH, make it more alkali down below. And that's difficult. It's difficult to work out the key ingredients there. So estrogen, containing or DHA containing is going to actually help the cells. Lots of the moisturisers and lubricants out there. There's quite a varied range, but you can get a lot on prescription. You can obviously buy lots over the counter. So it's looking at what's available, making sure it's not perfumed and irritating.
I mean, for us as dermatologists, we like things as bland as possible.
Yeah.
However, it isn't very sexy, is it?
No.
And so that's why I think it's opened up the entire market of lubricants that are different smells and different flavours and different consistencies. And those being used in random one-off ways might not be as problematic as somebody who's using the same kind of lubricant every single day, whereas that might build up and be a bit of a problem if you were doing it with nice kind of, I don't know, tasty ones. If you were to, say, create a perfect kind of cream for somebody who was in the perimenopausal time, what would that look like and what would that practice be like?
So firstly, something that's very user-friendly and people are going to enjoy using it and it works well. Something that's non-perfumed, has the correct lubricating ingredients to it. So there's different qualities to that. So for example, in hydromol, those kind of emollients, they work quite well. But really something that contains estrogen is really important, or a derivative of estrogen. So you've got the E2-3, there's different breakdowns of estrogen that we use to really help that tissue formation.
What's E2-3?
So estrogen is just the blanket term, but you've got the estriol 3 or 2 is what's in the different creams. So estriol 3 is weaker.
Okay.
So there's 4 types of estrogen when you break it down. So estrogen is the kind of blanket term, but actually what's the ingredient is estriol. So you've got estriol 2 and estriol 3, and they've got slightly different strengths essentially, but most of the products that are on prescription have those. Certainly if you're buying anything or using anything new, you want to think about the active ingredients. So anything that's moisturising is going to actually make a difference and contribute to that collagen strengthening. And estrogen overall really helps that. And one question I had for you is in terms of, you know, when you're saying what key ingredients, because I don't know if you've got any preferences in moisturisers or what actually, like, it's trying to break that down and work out what, I mean, the estrogen is the key active ingredient, but I don't know what you're thinking about that.
So from a dermatology perspective, a bit like you, the pH needs to be correct. It needs to be an acidic form of a pH. So the skin pH normally sits at around 5.5, 5.4. And in the vulval area, like you say, it's slightly less to have that optimal skin microbiome. So that kind of needs to be taken into consideration whenever you're doing things like washing the area.
Yeah.
I mean, one of the worst things that you could probably do is use just a typical normal soap that you might find in a hotel room or something, because that really just sends the pH completely awry. So it's about what the pH is. It's also a little bit about providing something that's going to reduce the water loss from the skin.
Yeah.
And that's applying something that is slightly occlusive in nature. And so quite a lot of the oils that we would use, so things like the shea butters or jojoba oil, they have an element to them that reduces that transepidermal water loss. And then partly the build-up, the kind of barrier build-up that you get, that needs to be strengthened too. And so often the addition of things like ceramides, which we use normally in the skin for moisturising, can be very helpful. So creating something that is the right pH, that has the right blend of occlusive agents to stop that water loss and is a softening with the ceramides would be key. And avoiding things that, to be honest, smell nice. I mean, it shouldn't really have any kind of a smell at all. Obviously, a cream has a smell, but no additional fragrance is added to it. Things like essential oils and all of these, it's just not necessary. In fact, potentially could be harmful. So that, from a dermatology perspective, is the kind of things that we like.
Yeah, that makes very good sense.
Whenever you see patients who come into clinic, because I get this a lot in the skin clinic, where someone will come in and say, oh, I'm not using my SPF because it's going to give me skin cancer, which it doesn't, by the way, obviously. But there are lots of myths and misconceptions around. What do you see most commonly or hear most commonly in the vulval clinic?
Gosh, that's a good question. I think it's maybe speaking to friends, so they say, oh, I tried, buy this, try this different thing, that will help. So maybe somebody's perhaps bought something that's felt quite nice to use, but they've not had a side effect from it and they're recommending it to friends. So maybe creams, that kind of thing, not helpful. So maybe information shared amongst their pals like that, and then they're causing irritation and infections. Certainly that normal part of ageing, I think, not accepting, okay, I've just got to live with this. I'm in my late 40s and actually I'm just going to feel uncomfortable down there, forever. So
don't do that, please.
Yeah,
anyone.
don't do that. And recognising that this isn't just a normal, in inverted commas, part of ageing. I don't need to accept this. There's things that can be done. What I didn't mention is on top of all those treatments, there's more specialist treatments. There's a tablet called ospemifene, and also laser therapy is there's an emerging space there around helping the vaginal tissues as well. But there's, again, not enough research or much material behind that at the moment. But I think we'll see that maybe being used for these really intractable cases. So women that we've tried everything with might need to see a specialist, and then that might be things that they can try.
Yeah, don't just jump in straight away for the vulval lasers.
Yeah,
there's a few dodgies around.
Well, that's it.
Okay, so I'll just read out some of the myths and we can say yes or no, okay? So the vulva and the vagina are the same thing. Well,
No, definitely not. So the vulva is that whole area, and the vagina would form part of that.
Yeah, the vagina is just that internal muscular canal. All vulvas look the same.
No, definitely not. God, I've seen thousands of them.
It's a bit like your face or your fingerprint, isn't it? No two vulvas are the same.
Definitely not.
I even say that whenever it comes to the Calera special, everyone's face is different, everyone's skin is different, and therefore your formulations are different. Mine's not the same as yours, not the same as yours. We could say the same thing for vulvas. Mine is not the same as yours, Ziggy.
And I think there's a website, actually, where you can look up different vulvas for young girls who are getting that imaging and they're thinking, I don't look the same. And, as friends, there's some website, I can't remember what it is.
I'm sure there's a few websites.
Be careful what you look up.
Okay, here's a good one. The vulva should smell like flowers or perfume.
No, absolutely not. So again, that's, I think, where that market is in these fresheners and washes, and all of these things tend to disrupt that healthy biome that we talked about, the vaginal microbiome. And that's often when you get problems with infections and the pH being off. So no, it should not smell of, anything. Everyone will have their own natural scent. And I do have perimenopausal people saying to me, actually, they feel their natural vaginal scent has changed over the years. But no, it should not smell of flowers or anything. And if you've got a kind of fishy smell or different bacterial smell, then that's when you might be thinking, okay, I might have an infection, and getting that dealt with.
Yeah, so if it smells badly like that, then perhaps you need to have that looked at. Yeah. But the idea of making it smell of flowers or perfume is not a good idea. And from a dermatologist perspective, we imagine that quite a lot of these fragrances, they can be really quite irritating for the skin for some people. And already the mucosa, which is in the vulval area, means that your skin isn't quite as protected as it would be, for example, on the back of your hand. And therefore, irritants and allergens can get in and then set up an irritant or an allergic response actually quite easily.
Yeah, and I always think of it as actually kind of very delicate skin, actually. Yeah. So the labia majora is on the outside. That's got the same skin as the rest of your, your arms and your legs. But it's as soon as you dip in from that labia majora, so where the hair comes into, from that inside fold, if you have a look with a mirror, you'll see it's a different type of skin tissue. And that's that really sensitive skin that definitely staying away from perfumes, moisturisers that have scents or smells. I think all I ever see from that is irritation, infections, urine infections even.
Another myth, hair removal is necessary for hygiene.
No, again, absolutely not. I mean, everyone chooses how they want to look downstairs, and I think there's no hygiene reason there to remove your hair, but obviously it depends on what you're comfortable with.
And in fact, probably it's really there for protection.
Yeah.
And probably it's creating such a nice microbiome so that you've got the right kind of lactobacillus there. It protects a bit against trauma because it's a bit of cushioning as well.
Yeah. And the hair in these areas is often for that protective factor.
And so if you were thinking about removing of hair, is there a way that is a better way to do it?
I don't think clinically particularly. It's got to be what's clean and safe. So I guess if you're shaving, I don't see many patients that are shaving. Most patients are using wax or A lot of patients have had laser actually for their bikini line, and that's worked really well. So always with a trusted clinic if you're doing that. Waxing's very popular, but again, you've got to make sure it's a safe use of wax. It's not too hot. Hair removing cream seems to be quite popular. Again, thinking about when the hair's growing back in and those ingrown hairs, making sure you look after your skin after you've had hair removal. I think if people are shaving, then it's absolutely crucial. The razor blade is clean and, the skin is nice and clean as well.
Yeah, I'm with you. I mean, I think all of those things are so important. But if you know the style that you want your pubic area to be, if you know what shape you want to be, because remember, laser hair removal is essentially nearly permanent.
Yeah.
So if you know how you want that to look for a long time, I think laser hair removal is going to be much better because you don't have that repeated trauma. You have about 6 sessions and then you've got that markedly reduced hair. But you do have to decide how you want things to look, and maybe the style changes.
The fashion changes. As a clinician of 25 years, we're coming up to 30 since our reunion, aren't we?
Yeah.
Or 25-year reunion. But actually, that's exactly it. Fashion's changed, so it's about what you like, what you're comfortable with. One thing I would definitely say is if you are doing hair removal, it's really important to try and avoid those ingrown hairs. Some of the boils and cysts and big infections I see as a result of the kind of ingrown hair, maybe it's not being dealt with quickly and it becomes quite a deep-seated boil, and that patient can be really sore, need antibiotics, and that's a bigger issue.
Yeah, absolutely. That's why I do like the lasers. And then there's one here that says, discharge mean that something is wrong.
Mm-hmm. So we've all got normal physiological secretions, and that changes with our hormonal cycle. So if you're a menstruating woman on your 28-day cycle, you will have consistently changes through that month with the secretions that are coming. And the body does that intentionally to try and help that sperm get to that egg, particularly in the mid-cycle. And lots of women, if you're in tune with that, will, I've got more discharge. It's a different, thicker consistency or thinner. We talk about discharge or secretion. So I would say secretions is the term really for normal, what we're experiencing on our underwear every day that changes throughout the month. And again, in the perimenopause, that can be quite variable. Discharge is, I think the term is used a bit more synonymously, but really any discharge, if it's smelly, uncomfortable, itchy, then it's that, have I got an infection here? I need to treat that. So it's really this term secretions a woman's going through regularly that I would say is the word that we would tend to use.
So Sigi, if somebody is having a problem with the vulval area, who should they speak to?
Well, in the first instance, you could definitely speak to your GP practice. Some practices might have a nurse practitioner or a practice nurse that can help you. Sometimes when you're having your smear, it's quite a good chance to say, or the nurse taking your smear might say, actually, it looks quite dry, you're having any symptoms. So that's an opportunity. The person that would then manage it is usually a prescriber. So if you've got a nurse prescriber, they might be able to manage it. Every practice is different. But generally, GPs can manage this well. But the problem is we know that getting access to your GP is really tricky and getting that appointment. So I wouldn't want you putting it off for ages while you're waiting for an appointment. You could presumably see dermatologists. In Scotland, to do that, we'd have to refer you, and the NHS waiting times are very long in Scotland. I'm sure they're similar down here. So we would be aiming to see someone within your GP practice, and you might then need to see a dermatologist depending on the condition that we're seeing.
And you can also then, through your private practice medical insurer, you can make that appointment with the dermatologist often directly.
So you could certainly access private gynae or derm. So I think either gynae or derm could deal with the vulval skin very well in terms of managing that. Yeah, because
the dermatologist would certainly think the dermatologist, and the gynecologist would certainly think the gynecologist.
Well, and again, gynae is often surgical for me when we're using private gynae, if I'm referring anyone. So yeah.
Okay, that's a wrap for today. It's been lovely and incredibly educational having you back on the After Hours Skin Clinic, Sigi.
Thank you, Emma.
And thank you for listening in. I really hope you feel more empowered and educated after listening to this episode. Don't forget to follow us wherever you get your podcasts, share us with your friends, and send in your questions on Instagram or email. And there are lots of details about everything that we talked about in the show notes. Okay, that's bye for now. Take care of yourself and your skin, and wear your SPF and lubrication if you need it. And see you next time at the After Hours Skin Clinic. As As always, this podcast is for informational purposes only and is not a substitute for medical advice. Please consult your healthcare professional before making a change to your treatment.